Good morning, everyone. Thank you for joining our ninth session of Research 101. I'm Margaret Lynn, Director of the Office of Clinical Research Development here at UTHSC, and I, along with Dorita Brand, the Program Director for the Tennessee Clinical and Translational Science Institute, want to welcome you. If you're just joining us, this is our, like I said, our ninth session, and it is one of an 11-part series to provide information for basic research study conduct. We're recording these sessions, and they will be posted on our website for viewing, and we're thinking that that will happen in July. We hope to offer Research 101 twice a year. But in between those offerings, we're going to offer some advanced courses. So just be on the lookout in your email and for notices about that, those advanced courses. I want to thank Electronic Research Administration at UTHSC for all of their help in producing this series. It wouldn't have been possible without them. Your Zoom has been, your microphone has been muted. So make sure that that remains muted throughout the session. We've had some pretty good luck as far as technical issues or resolving technical issues if they've arisen during the sessions. But if something occurs and we can't get it resolved, we'll just have to terminate the session, and then you'll be able to view it as a recording on our website. You'll be receiving an evaluation of the session by email, and after you complete that evaluation, you will be able to download a certificate of attendance. Dorita Brand and I, along with Risa Ramsey, who's providing support for nursing continuing education, have no real or apparent financial disclosures. Today's session is event reporting, SAEs, AEs, deviations, and other events, and I know our speaker, Carrie Palmer, will explain what those acronyms mean, but we're glad to have Carrie Palmer, MSN RN, today. She is the Clinical Research Coordinator Team Leader for the Office of Clinical Trials at the University of Tennessee Medical Center in Knoxville, Tennessee. Carrie's been a registered nurse since 1997. She obtained her MSN from Vanderbilt in 2019. She's been a classroom and clinical instructor for Lincoln Memorial University from 2011 through 2013, and she's been a clinical trials study coordinator from 2014 to present. And I believe that this topic, event reporting, is of special interest to her, and we look forward to hearing what she has to say. At the end, or actually during the session, you may use your chat function to ask questions, and then hopefully we'll have time for her to answer those. So with that, Carrie, I'm going to turn it over to you.
Hi, welcome to event reporting, everybody's favorite subject for clinical trials research. I know it is here in our office. We all get a little nervous sometimes about AEs and SAEs, which we'll talk about in a minute, and especially about protocol deviations. I believe that if you know what to do and why we're doing it, then it makes things a little less stressful for you. So we'll talk about that. We are going to start with adverse events, which are called AEs. Don't panic. I'm not going to read all of that to you out loud. Those are just the different definitions of what an adverse event is according to the different regulating bodies that we use for clinical trials here in the U.S. When the PI signs the 1572, he also commits to reporting adverse events to the sponsor that occur during the course of the trial, and that's in accordance with the Code of Federal Regulations. But basically, an adverse event is, they define it as any untoward event, medical occurrence, any change in health or worsening of baseline conditions. The worsening of the baseline conditions took me a little bit to get to grasp, so we'll go into detail about that in a little later. But for instance, if your patient has neuropathy baseline, so before they go on trial, and it has increased with severity while they are on trial, then that is an AE, even though they have a medical history of that. An AE also can be any new symptom. It can be an accident, or it can be a new diagnosis. And it's important to remember that an AE does not have to be related to the trial treatment. So the sponsor wants to capture everything, any adverse event going on with the patient, and then with the assistance of the PI, the sponsor will determine if it's related to their trial treatment. Just some examples of AEs: hypertension, nausea, vomiting, rash, anxiety, or like I said, worsening, so like a worsening headache. I just probably should have started with this. I have an oncology background for the last several years and do oncology clinical trials, so I tend to focus that way. So if you find me leaning that way, somebody use your chat and tell me to come back to baseline here. So why is AE reporting important? It's all about patient safety. AE reporting is the principal measure of safety of a new product and provides ongoing assessment for that patient's safety. We're developing a toxicity profile for a new medication for a lot of these trials or for a new device. That's a pretty awesome experience when you think about it. So we are the people coming up with what is on the back of your Tylenol bottle or what's in the insert that comes with the prescription you pick up at the pharmacy, which is why it's so important that we report everything that is going on. We report it accurately, and we'll talk about what you need, what information you need to collect when assessing AEs. But if you think about what the ultimate goal of a clinical trial is, they want to develop better drugs that can improve patient outcomes and quality of life. And if that's me and if that's my family, I really would like those improved results. Reporting of AEs is a major focal point in a clinical trial. And as we will learn, the more you do clinical trials, you will learn all about the paperwork that's involved with it. But despite all of that paperwork, AE reports are a necessary and integral part of any clinical trial. So when do we start collecting them? My first response to this is always refer to the protocol. Each protocol for each sponsor is different and may have you start collecting them as soon as you sign consent with the patient, or they may wait until the treatment starts. And the same as with the end of collection. It may go until you have your safety or end of treatment visit, may continue on after that. With SAEs, they are usually followed until they are resolved. At the end of a study, if the patient still has ongoing adverse events, they are usually just marked as ongoing. I did have one study, and only one study, that has said they needed an end date for it, and I had to continue to follow them and get an end date. And if you work oncology clinical trials, you know that we follow them for 15 years or so. So it's can be a little difficult to keep up with them and ask them every few weeks if they're still having heartburn. So the sources of information from AEs, we get them volunteered by the participant, more often the family. The participant will say, no, I'm not having any headaches, and you look at their husband, and their husband is shaking their head yes, or actually more likely the wife is tattling on the husband. So you can get it by the participant, their family, especially if you are treating pediatric patients, you want to check with their parent or guardian. You can get them by the indirect questioning, and we'll go over some questions. It can be detected by the physical examination, laboratory tests, diagnostics, or the patient-reported outcomes, the questionnaires that we give patients. Information that we need about the AE. So we're going to report an AE, and what do we need to know? Well, the first thing you're going to do is assess that AE. You want to know when it started, and if it has stopped already by the time you see them. When did it stop? What was the intensity? What brought it on? What were they using to treat it? So if we're using the example of a headache, their headache started 2 weeks ago. They rated as a 6 out of 10 on this pain scale, so you're kind of get an idea of the intensity. It's made worse with bright lights, loud noises. They've tried Tylenol to treat it, and it didn't work. So that would be the things that we would assess for that AE. When assessing for the severity of the AE, it's different depending, again, oncology has a little bit different system to use. Some Other trials outside of oncology may use just mild, moderate, and severe for their severity rating. In oncology, we use a grading system. We use a book called the CTCAE, and that is a book that is agreed upon terminology for the designation and reporting and grading of AEs in oncology research so that we all come up with the same terms and are able to use the grading system to have a congruent, I'm sorry, I lost my train of thought, a congruent line of thinking on what that severity is. That CTCAE is based first on signs and symptoms and also on the effect of the daily activities. You, again, want to always refer to your protocol for the specific requirements. Somebody may have a grade 1 sore on their tongue, mucositis, but the study only wants you to report grades 2 through 5. So always refer to your protocol. The next thing we need to know, is it serious? If it is serious, then it is an SAE, and we'll talk about those in a minute. And then we want to look at causality and attribution. That will help us assess whether there is a reasonable possibility that the drug is causing the event. The PI is the one, the investigator is going to determine that. He's going to have the input. For instance, when I work with my physicians, I may do my AE assessment in the room before he comes in to do the examination, and I meet him out in the hall and kind of review what the patient has told me. He asks a few questions, and then that gives him a better idea with his physical exam what to do and the questions for him to ask. So it's really an input between the patient, coordinator, and the investigator. The sponsor determines how we rate it, and where do we find what the sponsor determines? Of course, it's in the protocol. So sponsors may just say, is it related, yes or no? Do you think it, just cut and dry? We also have a rating system of definite, probable, possible, unlikely, and unrelated. Questions that can be helpful in determining attribution. So the physician may want to know, if this AE occurred before in the study? This is something that we may have to look into the investigator's brochure to see what's listed, if it's listed commonly, or if we've received a safety report about it, or an email from the sponsor, an updated consent that now lists something, a new AE, as more common than it was before. Is it reasonably temporally related to the to the intervention? So did we give the medication and immediately they had flushing? Then more likely it is, we are going to attribute it to that medication. And then, as typical in research, we want to know, are the results reproducible? So if we re-challenge them, did the AE reappear? Was it the same severity at the same time point? Was it exactly 30 minutes later they had the flushing after the injection? And then, are there any other potential causes for the AE? Well, their toes may be hurting and feeling a little numb and painful, and you start thinking maybe they're having some neuropathy, but actually they kicked the bed on accident when they were walking by that morning on the way to the bathroom. So what other causes could there be? And we need to know the action taken. Did we change the dose of the medication? Did we hold it? And they're going to come back next week for that intervention? Or did we discontinue it? Did we give them a medication to treat it if they're nauseated? Did we give them Compazine or Zofran? Did we do a con procedure? Did we take them and do a paracentesis because of their abdomen felt full, and then on X-ray and saw the CT and saw there was fluid, so we did this con procedure? Did we administer blood for somebody's hemoglobin that was down to 5? Were they put in the hospital, or were they discontinued from the study? These are all different actions that can be taken in relation to an AE. And then finally, we want to know the outcome. Was it resolved? Was it not resolved? Did it change in severity? Did it go from moderate to mild or moderate to severe? Did they die from the AE, or did they die from another cause? Documentation of our AEs. Several places we can do this. The source document that's completed during the patient visit, so wherever you're taking your notes, wherever you're writing down on that source document what the patient is reporting to you. sometimes we need to do a note to file, and that can provide additional information by using a short narrative. Supporting documentation is always needed. So if you have your AE is hypokalemia, then you're going to need the lab value with the potassium supporting that in the patient's chart. And then you have your adverse event log, and we'll look at a picture of what we use here at our site. And you may need a serious adverse event form. Those are per sponsor, per study, so they can be paper or part of the EDC. This is what we use at our site currently for our AE assessments. It just kind of gives some general symptoms so that we can have an open dialogue with our patients. And sometimes I find that when I ask them about swelling, and I'm thinking more cardiac reasons, a cardiac patient with swelling, and they report it somewhere else, and it sort of gets the conversation going. Or they'll say, no, I don't have that, but you know what, I have had this. So you want to keep this open-ended and elicit these responses. This is the adverse event log that we use at our site, and it lists all of the things that we just talked about, which sounded overwhelming, but really you can just boil it down to this. You have your term, you're assessing whether it's serious, you have your start and stop date. Again, I'm in oncology, so we have that grading, but you might be putting mild, moderate, severe, however the sponsor designates. The yellow areas are what our physician fills out. That was in an effort to get them to pay attention to just those areas. We still have to put arrow stickies and everything to get them to sign and write in what they need to do. I don't know if anybody else has that. So this is kind of funny to do this via Zoom and I can't see anybody's face or response. So the physician, the investigator is going to tell you if it's related to study treatment. So we have the 1, 2, 3, 4, 5, which goes to the, if you see at the bottom, relationship, unrelated, unlikely, possibly, probably, or related. And then if it is related or possibly related, then what is it related to? Is it related to the investigational product or giving an immunotherapy as an investigational product along with chemotherapy, which is the standard of care? So if it's related to the chemotherapy, they would write that name in, versus if it was related to the immunotherapy, they would write the name in of that drug. So we need to know what it's related to. And the action, we talked about which actions you would take. They're listed there at the bottom, and then the outcome. Then we always have the MD initial and date, the AE log. And then sometimes have to send it back because they forget to date. Some examples. So a patient has just given informed consent and completed screening assessments, but has not been randomized yet. The patient leaves the study visit and then gets in a car accident on the way home. Is this an AE? If your protocol says, as several of them do, that your AE collection starts as soon as the ICF, the consent is signed, then yes, this is recorded as an AE. My favorite is the patient becomes pregnant while on trial. Is it an AE? So pregnancy is not an AE, and I've heard that over and over at several investigators' meetings. However, all pregnancies during the course of a clinical trial must be reported. And you may be surprised, but I'll tell you to check with your protocol to see how they want that reported and what information they will need. We have a few challenges that come along with AE reporting. Sometimes the protocols, not sometimes, most of the time, protocols are complex and often involve multiple drugs and therapeutic modalities. A patient's prior therapies can affect the occurrence and/or severity of the AE. If we have somebody who has no medical history versus the patient that we may have all seen that walks in with diabetes and hypertension and hyperlipidemia and neuropathy and several other factors that can contribute to that. So many patients have complex presentation of their disease. And then also there are other, like we're saying, current medical conditions, but medications can affect the occurrence or severity of an AE. So it's always important to get a thorough medical history and a list of their medications. So serious adverse events. This is when Everybody holds their breath at our site to see when the patient's admitted to the ER and we get that notification. We hold our breath to see if they're going to be admitted to the hospital because we know that the paperwork then begins for an SAE. An SAE, or serious adverse event, by definition from the FDA, results in death, is life-threatening, and that led me to sort of look up what do we consider life-threatening. If you ask my daughter, a stubbed toe is life-threatening. But according to the FDA, the life-threatening is the subject is at risk of death at the time of the event. It does not refer to an event which hypothetically might have caused the death if it were more severe. And the determination of whether an adverse event is life-threatening can be based on the opinion of either the investigator or the sponsor. So also, as I mentioned a minute ago, an SAE requires hospitalization or prolongation of existing hospitalizations. You have a patient who went in for a routine procedure and developed a pulmonary embolus, and then that is a complication and prolongs their existing hospitalization. And also, if it results in persistent or significant disability or incapacity, if there is a congenital anomaly or birth defect, and then also based upon appropriate medical judgment, if it can jeopardize the subject's health and may require medical or surgical intervention to prevent one of the other outcomes listed in this definition. And just a reminder that severity is not the same as serious. So a minute ago we talked about the severity of the AE, and this we're talking about serious. Serious is based on outcome and is a factor in determining reportability, such as the subject is hospitalized as a result of the event. Severity refers to the intensity of the experience. Again, back to my grading, if I have a grade 3 of an event or of a headache or my headache is severe, that is the severity, or if it's moderate. So they're a little different but can often be confused. SAE reporting timelines refer to the protocol. Each protocol has its own definitions of when they would like SAEs reported to them. Normally, they're within 24 hours of site awareness of the event. If you are like our site, we work Monday through Friday. If we have a patient who is admitted on Saturday morning, we're not going to know about that until we come back on Monday at 8 a.m. So I see it Monday at 8 a.m. I have a notice that my patient was admitted Saturday. Then my 24 hours begins at 8 a.m. Monday, not from the time that they were admitted. For the initial submission, you may feel like you don't have a lot of information by the 24-hour mark, but you need to submit what you have. So the most recent clinical evaluation, baseline, and history and physical, that may just be an ER record at the time. They may not have had a physician visit them in the hospital yet to do a full H&P. You want to provide a summary of the event and treatment to date. So just a narrative of what happened, what brought them to the hospital, and why they were admitted. And then as additional information becomes available, you will amend your report. You will add in medications, lab values, diagnostic tests, and other things too. You will continuously do follow-up reports until the SAE has resolved. And that means for SAEs, it's, again, according to protocol, but usually even after the study has ended for the patient, they're maybe in the follow-up period, or even the follow-up period has ended. If they have had an SAE, we are going to follow that until it has resolved. Information that we need about an SAE. So we need the event term. Diarrhea, severe diarrhea brought their colitis, brought them to the hospital, and that's why they were admitted. We need their demographics. We need to know what the study agent or device was that they're using, the dates that it was given, the dose, and the route of administration. I've had SAEs that have asked me for the lot number for the last medication given, which you would get from the pharmacist, or here we do if you keep your own records, you would get that. They would like the lot and expiration number. You also want to know the causality, which again, Causality and attribution come from the investigator. You need to provide medical history that is pertinent to the SAE, the list of their concomitant medications, and then pertinent labs and diagnostics. And we don't need to provide them with every lab necessarily that they have had, but we need the labs that explain the experience or support the diagnosis. We also need a narrative summary of the occurrence, which is actually the most important part. It really gives the background information that the sponsor is going to need to know what's going on. It helps. We want to give information that describes the event, puts it in perspective. We also want to include any recent events that may be a contributing factor, and then you always need your investigator's signature. This is just kind of goes back to what I said earlier, that the FDA requires that investigators are required to promptly report to the IRB all unanticipated problems involving risks to human subjects and others, including adverse events that should be considered unanticipated problems. So now we are wanting to know, I have an SAE, and should I report it to the IRB? So that leads us to see, using that definition from the FDA, well, what do they consider an unanticipated problem? If you look over to the right, that would be my family when they come for Thanksgiving. Adverse events are just like house guests. They're only a problem when they're serious, unanticipated, and unfortunately related. So unexpected, they're unexpected in terms of nature, severity, and frequency. If they're related or possibly related, again, that comes from your investigator. And if it suggests that the research places subjects or others at greater risk of harm, including physical, psychological, economic, or social harm. Here's what we use at our site, one of the diagrams that we have that basically just helps us figure out, do I need to report it to the IRB? Because not every SAE is reported. Not every SAE is an unanticipated problem. If I'm giving immunotherapy to a patient, a common reaction can be colitis. That's not unanticipated. We know that that has happened in multiple cases. That colitis may have the patient admitted to the hospital for fluids. However, it's not unanticipated, so we would not report that to the IRB. So we go through all three questions. All three questions, the answer has to be yes. If you hit a no anywhere along the way, then you're going to stop because it's not an unanticipated problem and it does not need to be reported. So we're going to ask, is it unexpected in nature, severity, or frequency? Is the adverse event related to or possibly related to the participation in the research? And does it suggest that it places the patient or the subject or others at greater risk of harm? All three of those are yes, then we are going to report that to the IRB. Common problems with SAE reporting. So just some things that we've run into. The person assessing the event is not qualified to do so, so there may not be on the delegation log. They have insufficient or no medical training or licensing or whatever is needed for your particular study. The events are not appropriately documented. The reporting time frame requirements are not met. You're notified of the SAE and your 24-hour timeline lapses, then you are out of window out of that time frame. Protocol specified study procedures were not followed. So last but not least, I'm going to talk about protocol deviations. The first place that I worked at doing clinical research, if we had a protocol deviation, it was called into the office by our boss. The deviation went into a red folder. So I still have a little bit of PTSD when I discuss this subject. However, that's not necessary. It's important that we report all protocol deviations, that we don't try to hide anything, and we let them know what's going on. Sometimes a protocol deviation can be committed by several sites repeating the same deviation, and that will alert the sponsor to an issue with their protocol. These are the regulations, the ICH GCP regulations. We've all done our GCP training and probably made you a little bit numb going through all the modules. This just talks about the regulations. Again, I'm not going to read these out loud. So why is protocol adherence important? Strict protocol adherence important is more likely to protect our subjects and preserve the integrity of data and research. I'm going to go back to protect our subjects. Patient safety is a huge responsibility that we have. We're often administering medications that are not FDA approved and are, if we're in early phase, late phase 1, early phase 2, we may not know what really to expect with this medication. It's important to make sure that your patient remains safe. And then we always want to preserve the integrity of the data and the research. If we do not preserve that and our results are not reproducible, then that can cause problems for the entire trial and make the results not valid. So the reality is that within clinical trials, protocol deviations do happen despite our best efforts. So again, it's important to report them. A protocol deviation occurs when the activities during a study differ from the protocol. And that means in any way that the protocol has told us what we need to do. As a coordinator, I tend to focus on the assessment things, so not obtaining a wait during a visit is a protocol deviation. If my protocol calendar specified that I would get a wait at that visit, or if I needed to collect a TSH, a thyroid panel on the patient, and I did not do that, that is a protocol deviation. If the physician did a targeted physical exam and documented that instead of a complete physical exam, or if we performed a scan or x-ray outside of window. A protocol violation, again, is different. So, I'm sorry, a protocol violation often is termed as a major deviation. It depends on your institution as to the wording. So we're talking a major violation of the protocol. It reduces the quality of the data. More importantly, it can impact the subject's safety, rights, or welfare, and affect that integrity of that data. Some examples would be an inadequate informed consent. We just handed them the paper and they read all 27 pages, they didn't read all 27 pages, just signed at the back, trusted that you said it was a good idea to do it, which you also should not do. Enrollment of subjects not meeting inclusion/exclusion criteria. I had a patient one time that the protocol specifically said they needed to have a washout period after radiation of 14 days before randomization. Well, I was trying to be prepared to randomize so I randomized my patient 3 days before their visit, thinking I'm prepared, I got this going, I will be ready for her visit. But I read the protocol to mean 14 days before starting the treatment, but the protocol actually said before randomization. Had I not randomized them until the day they started treatment, I would not have had a major deviation or protocol violation, but I ended up with one, even though they did not start the treatment until after that 14-day washout period. Another example would be an improper breaking of the blind of the study, falsifying records. If we had frequent minor deviations, or a failure to withdraw a subject meeting withdrawal criteria. We left a subject on study who had a CT scan that showed that they were progressing on trial with their medication, then that would definitely be a major deviation. So who discovers the deviations and violations? We do. We know when we forget something. We realize when we get back after the visit, or we're entering our data and realize that we did not do something, and that's when we should report the protocol deviations. Also, they can be discovered by the participant, sometimes and oftentimes by a monitor, and hopefully not by an auditor. Reporting deviations, it's important to do these 3 things. They want to know what happened, what was your deviation, why did it happen, and what are you going to do about it. So regardless of the system that you're using to report your deviation, whether it's paper, iMatrix, whichever system you're using, it is important to document all 3 of those things. Excuse me. So what can we do to prevent deviations? We need to review and understand the protocol. In case I haven't mentioned that a few times, it's all about the protocol. It's going to give you your guidelines. You want to identify new procedures in the protocol that differ from your standard of practice. I had a protocol deviation one time because my patient's platelets dropped to what was an acceptable level at our institution in the infusion room. It was okay to go ahead and give that treatment. I didn't double check it against the protocol to realize that the protocol had a stricter standard as to when to hold the treatment, and we gave it when we should have held it. Using well-designed study-specific source documents. I thought this when I first started working with my current supervisor. She wanted specific source documents for each study, and I wanted one standard sheet that I could use for all studies. Unfortunately, she's sitting right here when I have to say she was right. The study-specific source documents do work a lot better. They increase our adherence to the protocol, help us to prevent deviations. You want to make sure that your staff is trained. Another thing that you can do is study initiation meetings. We've started recently doing this at our site. After our SIV or site initiation visit, the primary coordinator then meets with the other coordinators for that disease type. So for oncology, we would all meet and go over it. So if another coordinator covers for that primary coordinator, they have heard the information that they need to know about the trial. You want to make sure, again, that everybody is credentialed. You want to carefully review amendments, and you make sure that you use the correct version of the protocol. And that kind of does it. I'm sorry, I'm a fast talker. I tried to slow down, but does anybody have any questions?
Yes, Carrie, there are a couple of questions here. Can you go over the definition again of serious versus severity?
Absolutely. I'm going to just flip back to that slide. Am I there? Sorry. So when we're looking at severity, we're talking about the intensity. If we have a headache, is that headache mild, moderate, severe? How intense is it? If you're in oncology and you're grading that headache, is it a grade 2 headache, which means that you're administering medication for that headache? So we would look in our CTCA ebook and see what criteria meets that grade 2, and that's how we judge severity. Serious is based on an outcome and is a factor in determining the reportability. So was the subject hospitalized as a result of the event? Was that AE serious? Did it meet one of these criteria listed here? It resulted in death, life-threatening. Hospitalization is probably the most common one that we see. And then you always have your disability or incapacity. We had a patient who had a Taxol, I believe it was, and caused severe neuropathy to the point of disability in his right hand. So that was counted as an SAE for us. Does that help?